Old Guy Talks is all about creating a kick-ass life for yourself and those that you love. Don't wait. Don't hesitate. Don't procrastinate. Opt in now. 2, 1. This is Oris, the old guy, government certified because he has a Medicare card from www.oldguytalks.com, helping older guys create kick-ass lives for themselves and those that they love. Today, I have Dr. Keith Nichols, MD. We're going to be talking about all things you need to know about testosterone. And Dr. Nichols is a world-renowned expert. And when I say expert, we don't have enough time to read his bio. It's actually, folks, it's 2 pages long, all written in size 4 font, very small. Just I'm going to give you a few highlights here. He's the medical director and CEO of Tier 1 Health and Wellness in the Southeast. And he's program dedicated to promoting optimal mental, physical, and sexual health throughout the aging process. And he's recognized as an expert in the area of testosterone resistance syndrome, which we're going to talk about. He's board certified in physical medicine and rehabilitation. He's served as team physician for the Nashville Predators, Ultimate Fighting, Strike Force, Tennessee Titans, and other college and worked with other college and professional athletes. He's a lifelong fitness enthusiast and believes in bioidentical hormone replacement therapy when clinically indicated. And part of it has to do with, as he expresses on his bio, part of his personal story, which we're going to get into also. And but now, before I get started on this, Sue, the IP lawyer, wants me to read this, and so this is not, and just so Keith, this is not the way that she would have written it, but she says it works. It covers the basis. This is information only. Consult with a proper professional before starting any program, especially on this subject. Don't be stupid. You are responsible for your own shit. The old guy is a capitalist and now a socialist weasel. He may be promoting stuff, and when he does, he expects to be paid. The old guy only promotes stuff he uses. You will have different results because we are all very different. So don't expect the same results that I got or anyone else. You will have different results. So now Sue is happy, and we can proceed with the interview. So let's talk about. Let's kind of start off with what is going on with testosterone in men in the now and over the last few decades.
Oh man, you've seen a significant decline in men's testosterone levels. I think one of the main studies that pointed that out was in 2007. It was published in the Journal of Clinical Endocrinology and Metabolism, and it was entitled "A Population Decline in Serum Testosterone Levels in American Men," and it was authored by a lead author by the name of Dr. Thomas Travison. And in that study, he wrote that there was a substantial now age-independent decline in testosterone that did not appear to be related to lifestyle characteristics such as smoking and obesity. And everybody wants to blame it on obesity or smoking, but that's not in. In that study, we had a 17% decline from the late 1980s until the early 2000s. And that was a significant decline. And he goes on to say in his paper that it's possibly related to environmental effects.
Mm-hmm. Now, when you said something there, and I want to kind of go back to it. You said men in their 40s had more testosterone in the past than men in their 40s today. Is that correct interpretation?
And then from that study, men at age 40, or all age groups, every age group, in 1987 and 1989 had more testosterone than men in 1995 and 1997, who also had more testosterone than men in 2002 and 2004. That was the 3 subgroups of men that they looked at. So in essence, the men in 1987 that they tested from 87 to 89 had significantly more testosterone than they did in 2002 and 2004 through 2004.
Wow! So this is a generational impact of testosterone
levels. It is a total generational impact. That's correct.
Yeah. So what do you see as one of the reasons for this decline in testosterone? I know you have some opinions on that.
Well, I think that lifestyle factors do play into it. I certainly do. Of course, diet, exercise, that does play a role. Smoking, drinking, But that said, it's my opinion that the decline that we're seeing in both sperm counts and testosterone levels is environmental, related to our, unfortunately, endocrine disrupting chemicals that we're exposed to on a daily basis and have been over the last several decades.
Mm-hmm. Okay. And what kind of when you're talking about endocrine disrupting compounds, what would you say? Where do you find them?
Oh, they're everywhere. They're ubiquitous. They're you can't ignore them. They're in your drinking water. They're in the clothes that you wear, the makeup that you put on, the shampoo, the shaving gel. They're everywhere, and most are untested. So that's the problem. But they have a significant impact on our endocrine system. The way we test for toxins now is not adequately addressed when you test what endocrine disrupting chemicals do. You can't test them in the normal fashion that we normally test for toxicology. So that's a big problem.
Mm-hmm. Okay. Are these also in the food supply and everything? Would this be something like pesticides and GMOs and all that stuff?
Absolutely. They're in our food supply. You got to remember the small plant life, the small things eat, get it in their system. The bigger animals eat those animals, and we're at the top of the food chain. So we're actually the most affected.
Mm-hmm. So when you talk about this, what's the physiology on this? How it gets disrupted?
Right. Well, EDCs. Let's define them first. An endocrine disrupting chemical, better known as an EDC, is an exogenous, meaning non-natural chemical or a mixture of chemicals that interferes with any aspect of hormone action. So let's take testosterone or an androgen, for example. Androgens are completely receptor dependent. They have to bind to the receptor inside the cell in order to exert a response. Once it binds to that receptor, it undergoes a few processes called transcription and translation, and ultimately will exert an effect, which is usually protein synthesis. So anything that interferes with those processes will cause us to have symptoms of a deficiency. So we can have all the testosterone we need outside the cell, but if it can't bind to its receptor, it can't exert a response. And that's the problem. These EDCs are interfering with our ability to metabolize and utilize testosterone.
Okay, so it's not necessarily even the level of testosterone that can be in a man. It's actually the ability to utilize it.
Well, then that's the major problem that I see and that we have. Not only are we producing less due to the EDCs, our ability to use what we have is being interfered with.
Okay, all right. And you touched upon sperm counts. Tell me about what's going on with men's sperm counts.
Well, I think the most quoted study is the Hebrew University study that came out in 2017. And they looked at men between 1973 and 2011 in the United States and Europe. And they noted a greater than 50%, more than 50% decline in sperm in those men in that time frame.
Mm-hmm. And if you extrapolate it out, what does that mean on a long-term basis?
That means our ability to reproduce is being significantly affected. So it might affect us as a species altogether. And I think the problem is not only are we decreasing the quantity of sperm, but the quality is also decreased, which a lot of people don't talk about. Not only are we producing less, but their motility, is gone down as well.
Okay, so it's just it's both a qualitative and quantitative drop.
Both the qualitative and quantitative. That's right.
Yeah, that's a double whammy.
It is.
How do you see this? Because at this point, older guys expect testosterone deficiency, but I keep on hearing from some of my urologist friends and some other doctors that they're seeing younger and younger men showing up with testosterone deficiencies. What's been your experience in this?
The same. You're seeing a great many late 20s, early 30s, which I consider young, coming in with significantly low testosterone or testosterone right there in that intermediate range, which is in your 300s. So you're seeing most of them come in their 30s, literally in their 300s. Very rarely do you have a man come in with a testosterone 400 or 500. That's very rare anymore. Now, granted, of men that have significant enough symptoms that lead to seek help. So I've got a skewed population of men, but all that I'm seeing that are symptomatic in their 30s are in the 300s, and that's, I don't think 30 years ago most of us in our 30s were walking around with a 300 level testosterone.
No. I think, there was an article, and I believe it was in the Atlantic a few weeks ago, that talked about this whole thing. Testosterone is so important to your sex drive, for your libido.
Mm-hmm.
And there was this talk about how younger men and younger women actually have less sex.
They do.
Than let's say our baby boomers or even the generations behind that they're really showing up and there's no real particular reason, or they didn't really could identify in this article. I just wanted to go like
Mm-hmm.
Excuse me, you need to look over here. but that's a real concern, that the whole thing about because testosterone means so much of your identity as a man.
Sure.
And so if you don't have that, especially as a younger man, I mean, right. I was pretty easily excitable when I was in my 20s and 30s. I was really easily excitable.
Right.
Sometimes too easily excitable. That can work kind of against you sometimes.
It can.
So let's talk about these numbers. Numbers, because I have I talk to friends about this and this and that, and they go, well, my doctor told me that I'm normal. And I look at them and I go, well, first of all, you're not normal, but you're really not normal as far as testosterone goes, dude. Yeah. Yes. I mean, you're slumped over. You have no muscle mass. That's you're dragging. But is
that not the normal? Look around you. Is that not the norm right now, for the most part? If you really look around you and look at what we define as normal. Well, the levels, okay, of course, we've already established the fact that they decreased significantly from the 80s to the early 2000s.
Correct.
All right, so back in 2006, there was an article written, in Dr. Morgenthaler was actually one of the authors of that article, but they talked about the different normative values in various laboratories, and at that time, some labs had a normal value of 1,593 nanograms per deciliter. So in the early 2000s, I mean, 1,500 was a normal range. But then subsequent to that, our normal range, from LabCorp was 348 to 1197. And then the same author, Dr. Travison, wrote and did another project called the Harmonized Reference Ranges for testosterone levels in U.S. and Europe. And so they looked at 4 groups of men, and they developed a normative value based on some of those men. And that new normative value as of July 2017 became 264 to 916. So we went from 348 being the low end of normal and 1197 being the high end of normal to 2017. On July of 2017, those normal values went down to 264 for a lower end of normal and 916 for a higher end of normal.
Yeah, so that's a huge drop.
Right, and if you were normal, let's take it this way. So if you were normal and feeling well, and let's say you were taking testosterone and you were 1100, well within the normal range. The normal range was 1197 before 2017, July 2017. And then all of a sudden, after July 17, you become what they'll term supraphysiologic. So now you're taking too much testosterone, but yet you were normal the year before. Mm-hmm. Now you're not normal. You're over normal. Our normative values have just declined because what we're doing is we're taking the average of a population of what I term sick, poisoned men. We are literally being chemically castrated by our environment. So the normal values for testosterone are the equivalent truly of taking a group of people that have cardiac, they are compromised with regard to their cardiac functions, the heart function. So let's say they don't have a good ejection fraction. They just have bad cardiac function. And we use those as the normal. We take that sick group of people, and that's our new normal for cardiac function. And that's what they did. That's what they've essentially done with testosterone. We've taken the average of a population of sick, poisoned men and made that our new normal. But does normal mean healthy? Now that's where it comes in. Is normal healthy? Well, look around you and you look at the normal, you know it's not healthy.
Yeah, you see that, and it's frustrating when you're trying to talk to someone. I'm sure you experience it when you start talking about normal is actually average, and it's average of unhealthy people.
That's
It's not.
exactly what it is.
Yeah, it's an average of unhealthy. It's the same way if you looked at weight.
That's right.
It'd be the same thing. Well, that weight is not. Yes, it's average and it's in the quote unquote normal, but it's not healthy.
Well, we're also brainwashed and trained from such a young age that if you fall within a normal range, then that's normal. Anything outside of that is abnormal, of course. And so we as physicians were all trained. We've become more lab-centric instead of patient-centric. So we've moved away from treating signs and symptoms of a patient. Instead, we're treating the normal values on a piece of paper. So if you fall within that normal range, then you don't have the disorder. So we're just going to treat your symptoms with medications, of course. So, it's politics and economics.
Oh, sure. So a lot of times, are you finding that maybe treating people to their symptoms will take you in different areas of the ranges and things like that?
Well, sure. And so let's give an example. Low testosterone can present in many ways, various signs and symptoms. So, okay. Let's say a man comes in, he could have any of these and then some others. So let's say, one of the, most common findings is going to be a reduced sexual desire, decreased libido, decrease the number of morning erections, erectile dysfunction itself, fatigue, physical exhaustion, irritability, depression, poor concentration and memory, weight gain, excess body fat, decreased muscle mass, decreased strength, decreased energy, motivation, initiative, self-confidence. For me too, I had joint pain and muscular aches. You just have a decline in your general feeling of well-being. But if your testosterone level is normal, 350, 320, which is well above 264, well, it can't be decreased testosterone. Let's treat all those other symptoms because you must be depressed. You must need a Cialis, Viagra, PDE5 inhibitor. So, you have all those issues, and because they're non-specific. That's true. But what do you do in a man like that has all those symptoms that has, quote, normal values of testosterone? The only thing I know to do is give him a trial of testosterone supplementation and treat those symptoms.
Sure. As an antidote, I think I told you I've been on testosterone for over 22 years, and I've pretty much done it all. Right now, I'm pretty comfortable with injecting twice a week. But I took a long trip with my youngest daughter to New Zealand, and I did not want to deal with border agents and things like that. One unhappy encounter with a customs agent can really sour your vacation and so I just left it at home and this and that. And I was on the phone with my wife, and about a week into the trip, she goes like, "What's wrong? What's wrong with you? You're really negative." And then about a few days later, I talked with her again. She goes like, "Are you taking your testosterone?" And I go, "No, I left it at home because I didn't want to." And she says, "Wow, that was pretty amazing in terms of your attitude." I think one of the things people think it's all about libido, but it's actually a lot about your mental attitude.
Right. It had nothing to do with libido for me. It was just physical exhaustion, just fatigue that's really is indescribable. It was just I was miserable. I literally thought I had some sort of cancer. Did $1 million workup, they call it, and didn't find anything. And so it was just a process of elimination to find out it was low T. Never in a million years would I even have thought that, the aches and pains that I would have. I'd get up in the morning. I literally, when I put my feet on the floor, my feet and legs hurt so bad. I could barely walk down the stairs. I'd have to cling to the railing because I was afraid I would fall down. I couldn't work out. Just the thought of it made me nauseated. So it was terrible. But, sexual function wasn't so affected, or so I didn't think. But I didn't have any erectile dysfunction. But I had a lot of the other issues that everyone else has. And only after I did a trial testosterone replacement therapy did I improve. Did I improve? The guys that are at rock bottom, I call it, and I was pretty much at rock bottom at just a progressive decline. It gives them their life back. We're not looking to be, Superman or anything like that. We simply just want a normal life back, nothing more than that. And those are the guys that I look forward to treating, to give them their life back, to give the husbands the wives their husbands back, the children their father back, and that's what I come to work for. I don't treat men for performance enhancement if that's one of their goals. There's other clinics for that. I'm trying to give men their life back.
Sure, it's a quality. It's definitely a quality of life issue, and again, a lot of it is your mental attitude about things. And then if you have a better mental attitude, you're going to have a better outlook on doing exercise, working out,
That's right.
just social ability,
Absolutely.
interaction, all of that, because otherwise you become kind of a shell of a person.
Well, I tell you, it was a blessing and a curse that I went through it myself, because I've, had discussions with some of my colleagues that don't do what I do. And their typical response is people need to, as you heard it before, eat less, move more. I mean, they would say, well, Mr. Smith would do so much better and feel so much better if he would just get off the couch and do something. Well, I'm telling you, as somebody who had exercised all his life, I could not get off the couch. There was no way you were getting me off to do anything. It was impossible. So until you've been there, you don't really understand it. Like I tell everybody, God bless all those people that are diagnosed with cancer. I got a false diagnosis of cancer for a 2-week period of time 2 years ago. And so, you wake up with it, you go to bed with it. So my point is, what I'm leading to that is that until you've had it yourself, you can think that, until you get that cancer diagnosis, you can think you know what it feels like, but you don't. And same way with testosterone. Us doctors, before I experienced it, we can think we know what those men feel like, but you don't. You really don't. And so that's what kind of led me into this practice anyway, is what I went through, and misdiagnosis and being told the same things that everybody else has told me, and put on every antidepressant you could think of, having all the side effects of that, being addicted almost to Ambien and Lunesta to sleep. It was a miserable existence.
Yeah. Yeah, I think that one of the things that I've found for myself is I actually pick on my doctors, and I have two kinds of doctors. I have my anti-aging doctors, and then I have my disease doctors. And my disease doctors I actually pick on, because actually they're getting now to where they actually should be on testosterone.
Oh, yeah.
And I look at them and I go like, dude, you're slumping over. You're losing muscle mass. It's like, you need to. And by the way, all those things that you told me that were going to happen to me didn't happen. And actually, that's a segue that I want to get into right now. Is there are so many myths about the dangers of testosterone, and let's address some of those. Let's talk about heart disease. Let's talk about prostate cancer, all sorts of things. And I listened to a roundtable that you did with Jay, and I can't remember the other doctor's name, who's a big time clinical researcher. You probably would.
Dr. Howell, Scott Howell.
Yeah, I think so. It was just recently, because he was actually quoting a lot of literature. He was quoting a lot of literature. So let's talk about the myths and the safety of testosterone therapy.
Okay. Well, I can say just to start off that even though there's a black box warning on it placed by the FDA back in 2015, you realize that was done because of two highly flawed studies that came out in 2013 and 2014, the Vegan and the Finkel study. But I can say that in no randomized control trial since testosterone has been invented has it ever caused a heart attack, stroke, or blood clot in and of itself. I cannot tell you that that's occurred. What we do see is that it's cardioprotective. When you look at the cardiology literature itself, put out by the Mayo Clinic and cardiology journals themselves, they'll tell you about the cardiovascular protective effects of testosterone. You give it to men with congestive heart failure, they'll improve.
Yeah.
Go ahead.
No, go ahead. I'm sorry.
So, with regard to prostate cancer, we used to think that giving testosterone was like putting gasoline on a fire. Well, it's not. The only time that testosterone will make a prostate cancer grow is if a man has a castrate level of testosterone to begin with. Any level over 240, 250.
What's that term mean? Castrate level?
I mean, in very low testosterone, as if you're castrated. So you're talking about men in their hundreds, or less, So, but any level over 240 has been shown to not have any effect on the prostate cancer growth. It's fully saturated, and that's the saturation model, as noted by Dr. Abraham Morgenthaler, the brilliant urologist at Harvard. So, it doesn't make it grow with a level over 250. It doesn't cause it. It actually helps prevent it. The men with low testosterone are at the biggest risk of prostate cancer, more aggressive prostate cancers.
Exactly.
We know that. Men believe that it causes polycythemia vera, which it doesn't. So a lot of men come into the office that have iron deficiency anemia, where they've been phlebotomized, in other words, given blood so much, once again, if I can tell you that it hasn't caused a stroke, a heart attack, or blood clot since its inception in any randomized control trial, the erythrocytosis that you get, which is the increase in red blood cells, is a beneficial effect of testosterone. So it's going to raise your hemoglobin hematocrit. What does that do? That increases your endurance. That increases your oxygen carrying capacity to your muscles and to your other tissues. That's why we can give it to a diabetic man with ulcers and improve the healing of those ulcers. So there's a misconception there that it causes blood clots and that you need to be phlebotomized, that it causes prostate cancer, and it doesn't. That it causes cardiovascular disease, it doesn't. It's protective against cardiovascular disease. I mean, look, it decreases insulin resistance. It decreases visceral body fat, which is responsible in and of itself for at least 13 different cancers. Tell me why we don't want to maintain our testosterone levels in a healthy range.
Mm-hmm. Yeah, it's absolutely amazing, and it's frustrating, and I think a lot of men go in and they get told that, oh, you're in the normal range, and then they've got to, like, okay, they just accept that and say, okay, well, go ahead and give me all the other meds, and the next thing you know, you got those pill boxes for every day of the week.
That's right.
And you end up buying bigger and bigger ones all the time because you got to cram in more pills.
But that's a great consumer of that's what we need. That's what the system needs to survive. They need consumers.
Mm-hmm.
If you're not providing prescriptions, doing surgery, or being admitted to the hospital, the whole system breaks down. It's a business. It's the biggest business. So the business needs consumers. It's not about prevention. It's about treatment. So we're trained to treat with medications or surgeries, and we're trained to diagnose and treat the symptoms. None of us were really trained in prevention. Nobody goes to their physician and says, "Hey, doc, tell me tell me what I can do to not ever come see you." Well, he wouldn't know what to do.
Yeah. My other caveat is that if you are looking for a doctor in this space, that you better want to look like the doctor.
Yes.
I mean, if it's a disease doctor, I don't care. He can be morbidly obese, whatever. If they're an expert in that particular area, they're the best stent surgeon or the best this or that or whatever. I don't care. But if it's like going to a physical trainer. You better want to kind of look like them. Or they you want them to be setting an example for you versus the other way around.
If you're not buying what you're selling, why wouldn't somebody else? You know what I'm saying? I mean, I agree. Yeah. I agree with that. I mean, you better buy what you sell.
Yeah. So there are now just, ad after ad after ad for ED, for testosterone, for everything else. How it's such a cash business, and actually testosterone is relatively inexpensive. And what's the how does someone out there looking to find a credible doctor, a knowledgeable doctor in this area, what are the things that they should be looking for?
Well, let's talk about several points you just brought up, and we'll get to that one as well, about the fact that it's mainly cash and not insurance-based. Mm-hmm. There's a misconception why that is out there. And let's just put it this way. For us as physicians to use insurance, let's say, we have to give you a diagnosis code. So you have to have a diagnosis. And so to get a diagnosis of hypogonadism, you have to have 2 morning tests of less than, now it's 264. They have to be fasting. Why do we take it in the morning? Because that's when testosterone levels are the highest. Why do we do it fasting? Because food will decrease testosterone levels. So therefore, we want to test you when you're, in a point to where you most likely will not meet criteria for hypogonadism. All right. So if you don't meet criteria, you can't provide them with a diagnosis code. Now, if you submit to insurance a person with a diagnosis code that didn't meet criteria, that's essentially an insurance fraud. And most men come in with levels above 264. If you came in with a level of 267, you're above that. So you don't meet that strict criteria of having signs and symptoms and unequivocally low testosterone levels on 2 occasions in the morning. So I think that's where the misconception about the insurance is once again, in order to get one, they have to meet criteria for that diagnosis. Once you give them that code, they submit that code to insurance for billing purposes. And if they don't meet the criteria and you give them that diagnosis, then that's fraud for insurance. So doctors get in trouble that way. So most of the treatment that's going on at the present time is off-label treatment to treat symptoms. And that's okay to treat. Most drugs are actually used off-label.
Sure.
So as far as how, I guess the question was what to look for and
in finding a doctor, in finding a doctor that's skilled in this area.
You should really vet your physician as you would anytime if you're going to have heart surgery or anything else. I mean, vet your physician, especially in this world. I will tell you, and I mean, I'm a little too honest for my own good and with regard to what I may say about these things, but what's happening in the hormone replacement world is the same thing that happened in the pain management world. Now, my initial training was in spine and sports medicine and interventional pain management, so I did injections to help people with their back pain and neck pain. But what happened is the pill mills opened up. As you know, I mean, pain management initially opened up a couple of decades ago, and it was all done for the right purposes. But unfortunately, over time, you started having all the pill mills, and now you've got the opioid epidemic. And once again, that was perpetrated by doctors, not just pharmaceutical companies. Had to have somebody to prescribe it. But nonetheless, so the HRT clinics are open up on every corner now, and the model used for those pain clinics is being used in these hormone replacement clinics as well. So what I would recommend everyone do is don't even go to a clinic unless you can get a free consultation. If you're pressured to sign up, pressured to sign any dotted lines, walk out the door. That's first and foremost. You should be able to have a 30-minute at least, or as many as you need, consultations, in an effort to ask all the questions you need. They need to provide you with literature and research to support what they're saying. If you walk in and it's a typical cookie cutter, meaning that I'm going to put you on testosterone injections once a week, once 2 weeks, you're going to be placed on an aromatase inhibitor, an AI, twice a week, you're going to be placed on ACG. In other words, just this little recipe that they use on everyone, that's something I would be aware of as well.
Okay. Actually, that's just where I want to go. Perfect. Let's talk about the use of HCG and Clomid with testosterone. What's your perspective on this?
Well, I mean, you have to tell every man that he has alternatives to testosterone when he walks in your office. So those alternatives can be HCG and Clomid. All right. I can raise a testosterone level with HCG and Clomid, but I just can't make a lot of men feel much better. I can certainly make their numbers look good on a piece of paper, but I may not make them feel a lot better. I don't find a lot of men feel much better on Clomid and HCG, but I can raise their testosterone levels and I can maintain their fertility with those drugs. That's predominantly why they're used, is to maintain fertility. Okay, but most men don't feel well on them. They just don't. They're true medications. They're not bioidentical hormones. So you can see problems. I see men that are on testosterone feel better once they're able to get off the HCG rather than be on HCG and testosterone together. But those are alternatives. You give men all those alternatives. You give men all those alternatives to treatment. But I don't think anything works. Of course, nothing works as well as testosterone in and of itself. But in a young man, your primary goal is to preserve fertility and make them feel better. So, the first option would be HCG and Clomid, and they may be one of those men that feel better on it. But most don't.
Okay. Aromatase inhibitors.
Oh goodness, yes. Okay.
So before we get into exactly what those are,
Yeah.
What's the verdict on nipple sensitivity these days?
I like nipple sensitivity, man. I mean, I don't like nipple pain, but I don't mind the sensitivity. Tell me what's wrong with that. So I've had to use an aromatase inhibitor in men about twice, maybe two times at most, and that would be for mastalgia, actual nipple pain. Gynecomastia, it's genetic, and about 60-70% of us men, as we go through puberty, get it. We actually get it, but a lot of it's secondary or pseudogynecomastia, which is due to an increase in body fat that can cause it. But aromatase inhibitors in and of themselves, blocking our estrogen, I think the most important thing men need to understand is that a great many of the beneficial effects of testosterone are directly due to its aromatization into estrogen.
Mm-hmm.
Now, think about this. This is the thing to really think about. Now, in over 80 years of using testosterone, in every single study showing the positive effects of testosterone, they didn't block or control estrogen. In the studies that they did cause harm. But the point is that in all these studies and over the decade, I'm almost a decade of using testosterone, showing the benefits, we raised every man's estrogen level by giving him testosterone, and he improved. We showed improvement. When we block it, we don't. So that's the problem with estrogen. I mean, it trickled down from the bodybuilding world when men were taking excessive testosterone doses that are in the tens of thousands. There's a lot of polypharmacy with bodybuilders, not on just testosterone. They're on multiple anabolics as well. So their estrogen does get out of hand, but that is not medical TRT. That is not medical TRT. So there's a difference between use and abuse. And so in those guys, they did use aromatase inhibitors or may need to use an aromatase inhibitor, but don't really see it in men on TRT itself.
Okay. When we talk about some of these lab values, what does it mean free versus total testosterone?
Well, testosterone, when you produce it, a lot of it is bound to proteins. It's strongly bound to sex-hormone binding globulin, weakly kind of bound to albumin, but about 1 to 3% is what we call free testosterone. And free testosterone is the active testosterone. It's what your cell's able to utilize. It's not locked down by a protein or by sex-hormone binding globulin. So it's what we actually have to use. So really, the most accurate measurement for a deficiency is measurement of free testosterone. That's what I go by. When I'm treating, I'm really focusing on the free testosterone levels.
Mm-hmm. Okay. And when you're looking at that, again, you go by their symptoms.
I do.
Okay, so you basically treat to their symptoms.
You treat the symptom improvement, and there's two things to talk about there. So you're treating to symptom improvement. You're trying to improve those symptoms, and we went over all those symptoms earlier. And then, once you get them to a good point, then that's their number. You don't treat towards a number, but we're taught in the guidelines to treat toward the mid-range of normal. But the mid-range of normal now is 450. Because 916 is the higher end of normal now. 1197 was the higher end of normal before July 2017. So what I'm really careful to do with my patients, and what I wish more people would do as well, is testosterone in some ways by some people is a little bit overhyped. And what I mean by that is they make people think they're going to be Superman. They're going to be a porn star at night. They're going to be like they're taking anabolic steroids and they go to the gym. It's like taking an amphetamine when you get up in the morning and go out through your work day. And then it's like taking a sedative at night. And then you just get up and repeat. It's not that way at all. If you take a man like you were, like I was, that's rock bottom, and you give them their life back, that's what you're trying to do. But men have the misperception that they're going to take testosterone and it's going to cure all their ills. It's a panacea, and it's not. And so I have a lot of conversations with men. I mean, if a guy's been depressed for 30 years, he's still going to be depressed, and he may still need to take his antidepressant if he's on it. Testosterone may not cure that. So I'll try to, teach that it's not a panacea and not look at it to cure. It doesn't overcome life. It doesn't overcome stress, a bad marriage, a bad job, overworking, having lack of sleep. It just won't overcome that, no matter how much you take.
Yeah. And if you have a bad personality, it's not going to help you there either.
You'll just be worse. Yeah. I mean, the point is these guys want to put all their eggs in the testosterone basket. And I really, it does them a disservice because they're never happy. Some of them will never be happy because they expect it to fix everything. And when it doesn't, they think they need to tweak something or change something, and that's not the case at all. They're not focused on the long-term beneficial effects on it. They're all focused on the feel good now. I want to be great. They always say, well, if I feel good, maybe if I took more, I'd feel great. That's not really what happens either.
Sure. Do you find that men that have been on testosterone for a long time, such as myself? Do you find that they need more as they get older, or it stays the same levels?
I haven't. I see that right now we just are able to stay at the same levels. There's a lot of misconception out there that the receptors get burned out or you're going to need more over time. That's not how the androgen receptors work. They're auto-regulated. So if you have more testosterone, they're auto-regulated. They increase in number. If you have low, they'll decrease in number. They're auto-regulated, but they don't burn out. You don't burn them out, and it's not like taking, unfortunately, it's not like taking a narcotic where you have to have more over a period of time. So that's not that way at all.
Yeah, I remember. I mean, because I've been 22 years, but I remember the time that people were suggesting that you get off for a few weeks and then go back on and cycle off, and that was not a pleasant experience. And then I think it's important for people to be careful about who they pick as their physician. I just had a friend who the blessing was that his doctor decided to take him off his testosterone. He was giving him testosterone shot every 2 weeks.
Of course, that's what the book says. That's what the book says. That's right.
And I said, you are on a physiological roller coaster.
You are.
It's like, it's the half-life is 8 to 10 days, right in that range, somewhere in there, and in 2 weeks you're back down to where you were at baseline. So if somebody wanted to work with you, and there's a link, your website is down below in the below us, so you can take a look at that. If somebody wanted to work with you, how's that happen?
All they have to do is give us a call or email us, and we'll be glad to get you in for a visit or a free consultation, of course.
Okay, and do you do telemedicine also, or?
I do telemedicine, California, Florida, Alabama, Tennessee right now.
Okay, all right. So there's a few states that you do, because I know that's
They just need to fly in or drive in and see us once, and then we can manage them off-site after that. But you have to establish the face-to-face contact.
Sure. All right. Well, any comments? We've covered a lot of ground here. Any comments that you want to make here at the end?
Oh, I don't know. There's so much to talk about. We could spend another 2 or 3 hours really discussing the details of it all. But I think you covered quite a bit.
Yeah, I think we did too. So, folks, if you are an older man or know of one who is grumpy, slouched over, shuffling about, irritable, and probably fat, with bad joints and a bad attitude, one of the things, I will not tell you one of the things they should look at. The thing that they should look at is optimizing their testosterone values.
That is correct.
And using it therapeutically. This is Oris, the official old guy at www.oldguytalks.com, signing off. And remember, it's all about creating a kick-ass life for yourself and those that you love.
If you are interested in creating a kick-ass life for yourself and those that you love, then become a member at oldguytalks.com and get access to the cave area, where not only do I have my interviews with doctors on cutting-edge therapies for erectile dysfunction, but I will have other things that are posted in there that will help you create that kick-ass life that you want for yourself and others. And we're going to be talking a lot about different kinds of vices and virtues. So opt in and become a member